Starting with this IC about algorithmic approach and analysis of retinal diseases. May I call upon Dr. Rajiv Raman and Dr. Paveen Sain on the stage, who are the co-instructors for this course. We have a couple of topics covering wide range from surgical macular conditions to AMD, pachychoroid disorders and all. There are 7 eminent speakers and we'll be talking about different topics.
Hello. Yeah. So we'll start the session with the first talk on algorithmic approach to decision making and prognostication in surgical macular conditions by Dr. Sunil Ganekal.
No, change it. Set it at
I would request Dr. Muna Bende ma'am to please come on the stage.
Oh, only is here.
Change it. It's Dr. George, it's showing. Sure, no problem. Sunil Ganekal. Thank you. Good morning, everyone. I'll be talking to you about algorithmic approach and decision making in surgical macular conditions. Let me focus on few of the common surgical conditions like full thickness macular hole, lamellar hole, VMT, epiretinal membrane, and myopic traction maculopathy. With concern to the full thickness macular hole, many factors you need to consider. One is the age, the duration of the macular hole, etiology, of course the most important thing being the spectral domain OCT features and the indices. Spectral domain OCT is the key investigation which helps in diagnosis, staging and assessing the prognosis, monitoring the response to treatment and assessing the tangential and the anterior posterior tractions. Macular holes can be graded according to the various sizes ranging from small hole to the giant holes. The holes which are less than 400 microns almost have got a 100% success rate, but the main concern is the worst outcome in the holes which are more than 650 microns. Various measurements you can take like inner diameter, basal diameter, height, the cystoid spaces, the macular angle, hole angle, and many things can be measured with the spectral domain OCT. So the important ones being the, as I told, mean linear diameter, basal diameter. Look for the associated VMT, cystoid changes, epiretinal membranes. With respect to the prognosis, look at the external retinal layers status, and sometimes the intraretinal cysts can be seen at the edges of the holes. So many indices have been can be measured, starting from hole forming factors, macular hole indices, diameter hole index. Some take into consideration both anterior as well as the perpendicular as well as the tangential tractions into account. But hole forming factor and macular hole indices are the two ones which take into account both the tractional forces, so are more reliable when compared to the other indices. You can, by using an image analysis, you can get both even the macular hole area index as well as the macular cystoid space area index, which have also has got a prognostic value in assessing the outcome of the macular hole surgeries. As we know, the post-surgery, it could be either type 1 closure or a type 2 closure. Some indices closely correlate with the type 1 closure like macular hole index, tractional hole index, cystoid space area index. Similarly, type 2 correlation have got a very good correlation with outer diameter and the macular area index and other indices. Please look into the external retinal layers. Sometimes in spite of a good closure, you may not get the good visual recovery because of the damage to the external retinal layers. The microperimetry, another important functional analysis, which gives a clue to the functional recovery rather than looking at the anatomical. It tends to correlate with the visual acuity, so we need to look into the microperimetry also. Coming on to the ACTA, usually the vessel density in the superficial capillary plexus is unchanged. In the deep capillary plexus is increased but returns to baseline at 6 months. Please look at the decreased vessel density in the deep capillary plexus around the macular hole, which could be contributing for the incomplete visual recovery. So, vessel density in superficial capillary plexus and deep capillary plexus does correlate with visual acuity, the retinal sensitivity, and renal retinal thickness at 1 year. How does the FAZ changes? FAZ evaluation is difficult basically because of the interretinal cysts which are present. FAZ diameter is larger than the mean linear diameter. The FAZ reduce after surgery. FAZ area correlates with the best corrected visual acuity and the photoreceptor recovery. So FAZ enlargement biomarker for the foveal reconstruction after surgery. So one need to look into the foveal avascular zone post carefully. The ILM peeling definitely works in smaller holes, but in a large holes, the success rate is not so high. So if you see a macular hole index of less than 0.5, larger peels probably have more than 4 disc diameter may be required sometimes than the conventional peel to get a closure of the holes. The various techniques have been described. For a smaller holes, probably ILM peeling and ILM flaps works, but if you move to the larger size holes, probably may have to look at the other adjunctive surgical maneuvers like macular hydrodissection or an insertion of an amniotic membrane or autologous retinal graft. These are the two charts which clearly shows that larger the hole, probably the ILM peeling may not be sufficient enough to get the closure and the good functional recovery. This is an algorithmic approach usually one should follow. If you tend to see small holes, probably ILM peeling helps. If there is a reopening or the non-closure of the holes, please look at the edges of the hole. If there are just a cystoid, the flat edges are there, probably you can consider macular hydrodissection. If just in good ILM peeling done, probably gas injection or air injection sometime can suffice to closure of the holes. If it is a large hole, probably consider ILM flap, hydrodissection techniques, autologous retinal graft. In extreme cases, if there is a long axial length and other things, probably one can consider the option of scleral imbrication also. Coming on to the next entity in the macula, that is a lamellar macular. As we know, it could be either tractional lamellar hole or degenerative lamellar hole. So, do we need to tackle all lamellar macular holes? Basically, when patient has got a visual impairment, the outer retinal changes, metamorphopsia, and associated phakic status or pseudophakic, you need to look at the lens status, then we can plan for the macular hole surgery. Symptomatic patients sometimes may, with an epiretinal traction, may benefit from surgery. But look at the lens status, sometimes the lamellar macular hole, but just by cataract surgery, one can get away with the lamellar macular holes than doing a lamellar macular hole surgery. But the concern here is conversion of lamellar macular hole into the full thickness macular hole, so you need to consider your cases carefully. Next, moving on to the epiretinal membrane, it could be either primary or secondary. Younger the age, better the prognosis. Lesser the duration, better the prognosis. Pseudophakic patients does well. Look at the metamorphopsia score also. One important thing one should look at in epiretinal membrane is the presence of ectopic inner foveal layer. The grading you can see on the spectral domain OCT, the stage 4 ectopic layers tends to do poorly when compared to the other things. It is the presence of ectopic inner layer, foveal layer is more important rather than the thickness is more relevant. So EFL has got a poor prognosis if it is the stage 4 EFL. Then look for the central bokeh abnormalities. It is seen in most of the tractional maculopathy. They tend to inversely correlation with the ectopic inner foveal lictus. It usually correlates with the worse visual function. Then look at the macula counter. Either it can have a dome, flat shaped counter. Dome shaped macula, if you got prior to surgery, they tend to do better than the flat or a depressed sort of a macula counter. So look at the counter of the macula. Then foveal recovery, definitely earlier the foveal pit recovery, the chances of visual prognosis is good, and the patient also tend to correlate, and they tend to correlate and improve with the best corrected visual acuity and the FSZ area. All these correlates with the early foveal pit recovery. If you can see a clear space between the ERM and the ILM, then the prognosis is quite good, which has been described with the term Sukima. So you will have a greater good peel and you will have good recovery. Look at the distortion of the inner retinal layers by looking at something known as inner retinal irregularity index, which is nothing but a length of the IPL by the length of the RPE layer. So if you got this is an important prognostic marker in the ERM surgery. Even the similarly outer retinal integrity, look at all the 4 outer retinal layers, you can grade them in fact, and it also helps in assessing the prognosis. If you tend to see the outer retinal changes, probably the recovery of vision is not so good compared to if you got inner retinal changes, which are mostly recoverable. The drill, another important thing, which is an important marker which helps in assessing the prognosis of the shorter the axial length, poorer the prognosis in a patient with an epiretinal membrane. So one need to look into the axial length also. If you see a FFA in these ERM patient, if you tend to see a microvascular leak in the macular area associated with epiretinal membrane, these patients tends to do poorly when compared to the other patients. So in a OCT angiography with ARM patient, reduction in you tend to see a foveal capillary distortion, changes in the FAZ, and the vessel density changes are also, it's a positive prognostic factor for postoperative visual acuity and macular sensitivity. FSZ area, if you see a less expansion of the deep FSZ post ERM removal, probably the visual recovery as well as the metamorphopsia score may not be the great things. The choroid, not much of relevance in ERM, but studies have shown pre-op satel AS perfusion will have a, so we'll have a prognostic, some good prognostic factors and the poor prognostic factors. You're looking at the photoreceptors, the ganglion cell layer thickness, the cost line, the external retinal layers, and the lens status, many things which gives a VMT. Basically, you should look at the couple of things. One is the type of adhesions, the visual acuity, and the thickness of the fovea at the baseline. What are the poor prognostic factor? One is the macular schisis, cystoid macular edema, duration more than 6 months, and the premacular fibrosis, all the poor prognostic factors. So small VMTs, you can observe large VMTs, associated ERM, more than 1500 microns adhesions, you need to do a surgical maneuvers. Moving on to the last entity, the vitreomacular traction, either you'll have a perpendicular forces causing macular schisis or a tangential forces causing the either lamellar or a full thickness macular hole. So what are the factors influencing the macular myopic traction maculopathy? One is the age, the axial length, the presence and size of the foveal posterior staphyloма. Macular hole with schisis type are associated with high risk of RD. Look for foveal detachment, vitreomacular tractions. But some are protective factors like reduced height of the posterior staphyloma, associated dome-shaped maculopathy, and greater choroidal and scleral thickness. These are some of the protective factors for the. We have got many treatment options: observation, buccal, vitrectomy, and scleral indentation. You tend to see a tangential traction, go for a vitrectomy with a foveal sparing ILM feeling. If you see a perpendicular thick forces, then go for a macular buccal. These are various grades which you can choose. If you move on to the grade C holes with associated with full thickness macular hole, probably you may have to look for an pars plana vitrectomy option rather than the macular buccal option. Thank you for your patient hearing.
Thank you, Dr. Sunil, and I think we'll, after this, we'll just take questions a little bit later. That was a very succinct approach to an algorithmic thing. So next I'd like to invite Dr. George. Dr. George is from the Aravind Eye Hospitals, and he will be talking to us about an approach to management and diagnosis in pachychoroid spectrum. Thank you, George.
Yeah, thank you for having me here and this opportunity. So let's look at an algorithmic approach to pachychoroid disease spectrum. Can we have the slides? So basically, we have a group of diseases with common imaging findings, especially the choroidal imaging findings in this group of diseases. So now it's an ever expanding spectrum of disease with newer additions happening almost every year. So the usual entities are pachyepitheliopathy, CSC, pachyneovasculopathy, polypoidal choroidal vasculopathy, focal choroidal excavation, and peripapillary pachychoroid syndrome. And very recently, pachyvitelliform maculopathy also has been added to the spectrum. So common to these diseases are reduced fundus tessellation and increased choroidal thickness, no consensus, but generally more than 400 microns thickness, either a diffuse thickening like this or a focal thickening. And more importantly, dilated hallous vessels, more than 80% of the thickness with overlying choriocapillary attenuation or compression. And early phase of ICG showing delayed choroidal arterial filling. And you have the dilated choroidal vessels, and in the mid phase, patchy areas of choroidal vascular hyperpermeability in patches. So these findings, imaging findings, are common to these diseases. So the first entity is epitheliopathy, which is nothing but non-specific RP changes with or without pigment epithelial detachment, a prototype case where RP changes overlying a area of choroidal vascular hyperpermeability on ICG, and a pachychoroid with dilated outer choroidal vessels. So in this entity you can have these called pachydrusen, which are more than 125 microns in size, and either they are singly or in pairs distributed all across the posterior pole, not like in a dry AMD where there is a thin choroid and there is a confluent drusen which is accumulated at the fovea. And here we have a thick choroid again overlying. Pachyvitelliform maculopathy is a distinct novel entity where you have no fluid again like PPE, but you have this vitelliform material accumulated, and should be aware of this entity because over the 5-year or 6-year you can say that it proceeds to something called pachygeographic atrophy. So moving to the next entity, that is CSCA, we all know that young patients, type A personality, acute serous macular detachment overlying a pachychoroid. There are variants like this when you have a fibrinous variant or an exudative bullous variant associated with exudative RD, or with PEDs and hyperreflective fibrinous material on OCT, whereas in chronic CSC we look at diffuse RP epitheliopathy, multifocal leakage, and diffuse ooze in the late phase of fluorescein angiography, OCT. You see these findings of intraretinal fluid. You have photoreceptor outer segment elongation associated with PEDs, and later on goes in for foveal thinning and atrophy. So as we were mentioning that Swepsore's OCT showed it could be a diffuse thickening or it could be a focal choroidal thickening, especially nasally or temporally. The best example in this scenario is peripapillary Pachy syndrome, which I believe is again a variant of CSC which happens in elderly and bilateral. So you have a nasal macular preferentially thickened choroid and nasal macular intraretinal and subretinal fluid. For example, in this case you can see on either side of the peripapillary intraretinal fluid, subretinal fluid, and this hypertransmission defect in the overlying the choroid on the peripapillary area, and the autofluorescence showing the peripapillary RP atrophic changes or mottling and peripapillary pachyvessels, and preferentially choroidal vascular hyperpermeability on the peripapillary choroids. So now with these variants, now what indications of management usually observe in acute case for 3 months, and if it recurs with visual defects or other eye has permanent visual deficits or chronicity signs which we saw on FFA, IC or OCT, then you need to treat, or if there is a patient need occupational or other need for early restoration of vision. So the commonest modality all of us know that is focal laser to the early FA point leaks outside the fovea, give very gentle grade 1 to 2 just visible burns, 2 to 3 burns to basically stop the RP leakage and minimal scarring in that area. So but when it happens in the subfoveal area or juxtafoveal area, you can't treat these cases with the conventional laser, because conventional laser has the problem with overlying neurosensory retina, that is a collateral damage. So that doesn't happen. So these short pulses of these laser to stimulate the RP. So that is what is being done in subthreshold micropulse laser and heat shock proteins, and then this fluid resolves in the micropulse laser. So various studies have shown efficacy. The current issue is a lack of a uniform treatment parameters, but it's recommended that it should be titrated based on an extramacular burn, and it should be sequential follow-up. So we are working on that, and soon probably we'll have a uniform parameter. So coming to the next modality, especially for chronic CSC, the gold standard is PDT, which causes a short-term choriocapillary hypoperfusion, but on a long term, in 90% or more of patients who have causing a long-term vascular remodeling and thereby decreasing the choroidal vascular hyperpermeability and no more recurrences. So half dose or half fluence are equally good and better than standard fluence PDT, and the Indian results are also 90%, which is comparable to the Western literature in such cases where you have chronic CSC and you have these kind of subfoveal PED and fluid, and fluorescein ICG showing a diffuse leak and leaking PEDs. So in this scenario, you cannot do any other treatments, injections don't work, so we have to go for PDT. So this is like the PED and the fluid disappearing after 1 month and after 3 months of half dose PDT in this patient. So there are some OCT biomarkers which determine the outcome. So one worse outcome is expected in when you have these large cystoid space, something called CMD or cystoid macular degeneration. This is a poor biomarker. Again, acquired vitelliform lesions. You see this hyper-reflective acquired vitelliform lesions in the subretinal overlaying the PED. Here you can see that's a poor biomarker, and you have after treatment there is no response even after a half-fluence PDT. So next entity is pachyneovasculopathy. This is nothing but a type 1 neovascularization on FA and ICG overlying a pachychoroid, and you see the PED, flat irregular PED. For example, this patient was referred as chronic CSR, this flat irregular PED, and then overlying, mostly it overlies a pachy vessel. So here the octa is very useful, superficial plexus normal, deep plexus normal. When you come to the avascular retina, you find this filamentous tangle network, and this octa is, this overlies the flat irregular PED on the fundus, and octa is very sensitive in picking up this network because the fluorescein and ICG angiography can miss this subtle neovascularization in the setting of a pachyneovasculopathy. So the last entity, PCV, is a serosanguinous maculopathy called as aneurysmal type 1 neovascularization. So still ICG is the gold standard in picking up where you have these hypercyanosin nodular lesions, but now we are moving to non-invasive imaging, wherein 3 major criteria Asia Pacific guidelines like sharp peaked PEDs and sub-RP ring-like structure and on-fast OCT showing this complex RP elevation have almost 80 to 85% sensitivity in picking up compared to ICG angiography. And in the recent recommendation, the on-fast OCT complex RP elevation has been replaced by color fundus photograph showing orange subretinal nodule. So because many clinics lacks PDT and ICG in treating PCV, so basically based on OCT octa based criteria, monthly injections of one of the newer anti-VEGF agents work better for PCV based on the PLANET study recommendation. Go ahead with anti-VEGF monotherapy after 3 loading doses. If there is persistent fluid, then go for ICG and consider PDT rescue. But with extended loading doses up to 6 months and treat and extend regime, even without PDT, there is a good polyp closure rates even with any of the newer anti-VEGF including faricimab, brolucimab or aflibercept or any of this. So focal choroidal excavation can also be part of the pachychoroid where it's a sharp choroidal excavation on SD-OCT. It can be conforming or non-conforming if the neurosensor retina is detached from the RPE, but treatment is not required unless you see this subretinal hemorrhage. It can be associated with CNV or PCV, and the good thing is that only fewer injections of anti-VEGF are required in this scenario to take care of the CNVM or PCV in this scenario with FCE or focal choroidal excavation. So the algorithmic approach would be, if you see a PPE or PVM, that is epitheliopathy or a vitelliform maculopathy, observation is sufficient. PPE should be kept in mind that it can proceed to CSC, and pachyvitelliform maculopathy can proceed to pachygeographic atrophy. So these patients should be aware and should be on a periodic follow-up. CSC is a choroidal disease now with swept source OCT and ICG showing features, and acute CSC is observation and focal laser for extrafoveal leak if it persists, and micropulse laser for subfoveal and juxtafoveal leaks. The criteria is yet to be defined with a uniform parameter, but chronic CSC and peripapillary pachychoroid syndrome, half dose, half fluence PDT is the gold standard currently, and pachyneovasculopathy and FCE associated CNVM. Octa is very important and sensitive and specific to pick up. Anti-VEGF therapy, only few injections are sufficient, and PCV is now moving to non-invasive imaging, and newer anti-VEGF monotherapy is the first line, and if persistent polypoidal lesion, go for ICG and combine PDT as a rescue therapy. So thank you for your kind attention.
Thank you, Dr. George. That was a very extensive coverage of the thing with a good algorithmic approach at the end. We'll take questions after we continue session.
Sure.
So I'd like to invite Dr. Muna. Dr. Muna is a wonderful teacher of all of ours and one of the finest minds in medical retina in this country. Dr. Muna, please. She'll be talking to us about the algorithmic approach and analysis in dry age-related macular degeneration.
Good morning, everyone, and thank you for being here, and thank you, Uni, for this opportunity. We know geographic atrophy evolves from normal aging to certain features at risk, and finally, clinical geographic atrophy, which causes a loss of vision. So my talk will be just to, I can't see this slide if you put this in the way, yeah. So my talk will just to tell you which are the features that we need to look at to predict progression of geographic atrophy. Now really, how significant is it in Asia? There was this study by the Asian Eye Epidemiology Consortium where they showed that the geographic atrophy actually had a lower incidence than the West. But if you look closely at the data, there were studies from South India which showed the geographic atrophy was actually a little higher, but they had to exclude them during the sensitivity analysis for lack of certain information. And most of these studies came from India, which shows that probably we don't have such low an incidence of geographic atrophy as the world thinks. And this is a table which shows us that there are various predictor models for ARMD and especially geographic atrophy. What is most important, there are numerous factors like age, education, smoking, and the genetic risk score, and also the severity scores at baseline and the fellow eye, and all these could be predictive of progression of the disease. And I think nothing describes geographic atrophy better than this article, which tells us we really don't know much about it at all. We don't know when it comes, but we know it progresses. How to stop it, we are not sure. And this table tells us that there are few shared criteria which tell us that incidence and progression can both be predicted. And most important is the genetic makeup of the individual, and I'll show you a slide later. Cigarette smoking is a well-known risk factor. The Mediterranean diet, but not its content, is a protective factor. And certain phenotypic features like reticular pseudodrusen and hyperreflective foci. Interestingly, there are certain factors that are totally contradictory when it comes to incidence versus progression, and the role of AREDS as well as complement inhibitor is still uncertain. This is one of my patients whom I diagnosed choroidal neovascular membrane in the left eye at the age of 41. I noticed he had drusen in the right eye. He's now 57 years old, and this was his fundus picture a couple of months ago. We had a project running on genotype in patients with AMD, and this actually was his genotype. He was homozygous for the ARMS2 gene, the HTRA gene, and the CFH gene, and the C2 gene. Why is it important? Because these are all risk factors. And another thing, why did he develop it so early? Because he had multiple homozygous risk factors. So if you see a patient with drusen at an earlier age, they are more likely to develop clinical geographic atrophy later on. This was a large UK-based cohort, which also told us about progression from early to intermediate to advanced forms. And they found that the status of the fellow eye also influences the rate of progression. One eye with GA, you know the other eye is going to go in for GA. And this was their table. And then part of the AREDS2 study was also to look at OCT risk factors of GA progression. What was significant is the presence of RP atrophy showed a very high incidence of progression of geographic atrophy, whereas absence of RP atrophy at baseline, the incidence of progression was much lower. What are the precursor lesions and how fast do they progress? Large confluent drusen, relatively slower, almost over a period of 6.5 years, whereas hypopigmentation seen as atrophy and hypertransmission on OCT can progress as fast as 2 to 3 years to geographic atrophy. How can we image these cases? Color fundus photograph. Autofluorescence is something most of us are familiar with. Quantitative autofluorescence, probably most of us don't do it yet. Infrared multicolor imaging, and as well as OCT. The various OCT factors for progression. a large volume drusen. So the large drusen can sometimes collapse and cause atrophy. This eye has not caused atrophy. Here you see the collapse, but there's still some deposition of material. Over a period of time, we expect that to progress to atrophy. Hyperreflective foci over the drusenoid pigment epithelial detachment eventually leads to atrophy. And there are certain changes which are at high risk, that is change in the character of the internal reflectivity of the drusen. Here you see hyperreflectivity, and you have the hyporeflective core. Again, hyperreflective foci, and interestingly, outer retinal tubulations, which we all thought were atrophy, where if you see it at the border of the area of atrophy, it's believed to be protective and protects it against progression. And I think most of us would have seen these in our cases, a large pigment epithelial detachment developing hyperreflective dots on the surface. Over a period of time, you see the content changes and ends up as atrophy. Usually takes about 4 years. Other known risk factors are reticular drusen, pseudodrusen, and calcified drusen, best picked up on fundus autofluorescence and near-infrared imaging. And we've all known that the CAM study group gave various risk factors for progression to geographic atrophy. What are the high risk factors are incomplete retinal pigment epithelium and outer retinal atrophy, such as iRORA here. Nascent geographic atrophy, where you see subsidence of the inner nuclear layer progressing to more atrophy over a period of time, and this is a 2-year period. And this was the study which showed the OCT findings of incomplete outer retinal atrophy progressing to complete outer and retinal atrophy. Here you see a uniform area of hypertransmission where there is intermediate irregular areas of hypertransmission indicating this is incomplete and this is complete, and this is a major risk factor for GA. Looking at the edge of the geographic atrophy, what do you see on the OCT edges? If you have a smooth edge like this, the risk of progression is less. But if you have an irregular edge like this, or if there is splitting, the chances of progression is much higher. Autofluorescence, we all know, is a very easy way to study atrophy, and there are various patterns of autofluorescence. The banded and reticular diffuse pattern is more likely to progress to GA. This is one of my own patients whom I'm following for a period of years. If you look at the autofluorescence pattern here, and you look at the autofluorescence pattern here over about 2 years later, you see that the area of autofluorescence is definitely increased, and there's some patchy abnormalities at the border, and you look at this hypertransmission on the B-scan OCT. And this was his other eye. Again, you see this was at presentation. This was a couple of years later. There is an increase in the area of atrophy. Various risk factors that are at high risk for atrophy. You have multiple areas of autofluorescence abnormalities, multifocal, extrafoveal is more at risk of progressing, and then you have patches like diffuse, banded, and diffuse trickling patches of hyperautofluorescence, which can cause a high risk of progression. In addition, thin choroid can also cause progression. And these are the various risk factors which are well known to cause progression of GA. This is a patient over a 72-month period showing the progression of atrophy. Can also be seen as choriocapillaries abnormalities. The CVI is also associated, but this is more of a research tool right now. And of course, AI will help us to correlate what we know already and maybe apply it to a larger data set. So I don't have an algorithm because there's not much to say in that, but these are the red flags if you see a patient with drusen. If the patient is younger, possibly carries a genetic risk factor, so the risks are higher. Environment like diet and smoking is easily adjustable. There's certain phenotypes like large drusen, reticular drusen, extrafoveal GA and GA in the fellow eye, which are at high risk. Use various imaging modalities to identify and monitor these patients. Look at biomarkers like the pattern of AF changes, the edge and the focality, and also OCT and drusen size. Thank you very much for your patient listening. I welcome you all to Chennai in July for our meeting. Thank you.
Thank you, ma'am. That was, as ever, it's a descriptive and thought-provoking talk you've given. Thank you.
Hello. Now I would request Dr. Unni Krishnan. He will be talking to us on algorithmic approach in diagnosing and prognosticating wet AMD. Unni.
Good morning, everyone, and thank you for being in this session with us today. So we're just going through politically correct neovascular AMD as a terminology first. So we have many clinical decision-making tools, and most of these tools are going to help us in prognosticating, deciding a treatment course, changing a treatment course, telling you when to stop treatment, and all these things. And the main two technologies we use are the OCT for a structural and OCTA for a vascular flow delineation of the vasculature. And by these erudite tools, we look at pattern recognition, layer segmentation, the depth analysis, a correlation between flow and structure, structural projection, and depth resolved progression. So how do we use these tools in an algorithmic approach for diagnosis, initiating treatment, and evaluation in the diagnosis? So a typical AMD picture, you have different diagnoses in different layers: above the retina, fluid compartments inside the retina, thickness of the retina, underneath the retina. And we have very simple types of classifications based on OCT about type 1, type 2, and type 3 CNVMs. We'll come to that later. Type 1 is underneath the RP, very obvious. The changes may be pre-RP, but the vascularity is underneath the RP. And the OCTA gives a filamentous kind of appearance with a darkness or a halo around it. That's a typical type 1 CNVM octa finding. A type 2 gives a more fusiform, a more lesion which is involving or breach the RP, and then you have a very compact lacy pattern, a very compact pattern in the OCTA. And you can see the difference on one side you have a very compact circular pattern, the other you have a more diffuse pattern with a lot of filamentous appearance. And this is a newer machine modality which brings out the difference well. You have the two different types of CNVMs. A type 3 CNVM is a newer type of concept evolving. It's a dual position of the neovascularization with two different layers, which indicates a very high anti-VEGF load and a very high proliferative rate. So I'm just going to, at the start, we look at the location, the type, whether it's a pre-RP, a post-RP, or is it extensive in many ways. The activity, we look if it's currently active. Is it overt or a smoldering activity by the nature of the OCT and the SRF, or whether it is inactive. You look for, is it a typical AMD type process happening, or is it a variant happening? And you look at the duration. Is it a new disease? Is it a reactivation? Or is it a chronic disease? So these are the first things at the point of diagnosis you look at. The location of the disease, whether it is smoldering, is it foveal by involvement or only by extension, and is the disease of new duration or not? So pre-RP disease and the post-RP, what are the implications? The pre-RP disease has the possibility of a long-standing or a chronic disease. A post-RP disease, that is penetrating the RP, is definitely going to have a more destructive course, damages the outer retina and the RP together. The pre-RP leads to a lot of atrophy, and the post-RP disease leads to a lot of scarring with atrophy. So for prognostication point of view, this is what you can have in your mind. Again, a pre-RP disease can be a PCV or a non-PCV, and PCV you have a type 1 and a type 2, and you can have the effects of having a bleed or an exudation if it's a PCV type disease. A pre-RP disease can be a focal disease or a disease that has gone wider and more diffuse. You can have a disease with a vascular SHRM, that is you have the tissue, the SHRM tissue is vascularized, or you can have a avascular SHRM. An extensive disease, you can have a mixed disease where you have a pre-RP and a post-RP component, or you could have just a recent breakthrough, a disease which is predominantly type 1, which has recently broken through and to form a type 2 disease. The type 3 is a different ballgame. The response to anti-VEGF is not so prominent, probably because of the intense or the elevated levels of VEGF. You have a potential of a twin-site neovascularization if it's type 3 disease, a huge VEGF load, as I mentioned, and it is a type 3 disease is quite quick to recurrences, and it's quick to atrophy also. So identifying a type 3 disease puts you in these new problems. Just skipping through PCV. So when you initiate treatment, you're looking at two things. if it's a typical AMD, that you're looking at signs of activity. So you have to, the importance is to initiate treatment. But when do you defer treatment? You defer treatment when you have nil activity. That is, you see AMD-like lesions, but you don't see any activity. That's what you call a non-exudative CNVM. Or you see minimal activity or doubtful activity or a doubtful diagnosis. We'll go to all these things. So a non-exudative CNVM is when you see an elevation or double layer elevation of the RP, and it looks fine, but you find that there is a vascular network on the OCTA. There are no signs of activity like SRF or CME, but you identify a vascular network. You can defer your treatment. You should defer your treatment, even and with a close watch, because nearly 22% of patients can develop into a clinically overt CNVM in a 1 year period. And this is another example of a non-exudative CNVM. Basically, non-exudatives are two types, where you have an angiogenesis with more capillary vessels and an arteriogenesis type with more larger filamentous loops, which can divide it into people who convert to an overt in a short term within 6 months or in a longer term beyond 6 months. The next is minimal activity. When do you defer treatment? When you see minimal activity. So when you see this patient, there is no signs of edema or IRF, but you see a slightly enlarging PED over a long period of time. So an enlarging PED is still the sign of activity, but it is not sufficient enough for you, maybe not sufficient enough for you, and you can defer treatment if the visual acuity is okay in this patient. So when do you have doubtful activity? When you have a condition called non-neovascular SRF. You have subretinal fluid, but is not neovascular. There are three types. One, when you see it on top of the PED or between two PEDs like a drape, or at the edge of the PED. These are the evidences or defined evidences of non-neovascular SRF, and you may defer treatment. And the next is a doubtful diagnosis, where you need to investigate further. You can have conditions like this, which is adult-vitelliform degeneration with resorption. You can see on autofluorescence how it lights up. And then you can have a condition like this, which is called a torpedo maculopathy, where you see it looks like SRF, but the condition is a degenerative condition. And obviously focal choroidal excavations, which again can look like CNVMs and their activity. When you start treatment, there are things that tell you to go, you need more aggressive and less aggressive features. The less aggressive features would be the presence of SRF and multi-layering as compared to, this is an example of multi-layering, which we have a layering underneath the RP, which shows a more stable but prolonged disease as compared to some other types. And these are the presence of laminate bodies under the PEDs, which again show a more subtle or a long-standing, comparatively stable disease. Again, we are in the era where we are thinking of tolerating SRF, and so SRF is now a more benign or better prognostic feature as compared to intraretinal fluid. The highly aggressive features are the presence of SRHRM, the presence of intraretinal fluid, large PEDs or macular involvement by the RPE. So an extra large PED is always a point of concern. Just wind up soon. The presence of SHRM, especially if vascular, is a high point of concern. And then we can think of the persistence of SHRM, which goes into the formation of a scar-like lesion and has a poor prognostication. And this is what you call a vascularized SHRM, where you find on OCT a vascular membrane underneath the SHRM, which converts to a scar. So I'm just going to skip this guide. The maintenance therapy based on the algorithm, you can either go for a PRN or a TAE. One is high reactive and one is proactive, and it's beyond the scope of this. The whole aim of AMD treatment is prevention of atrophy, prevention of long visual drops, catastrophic events. Treating IRF but observing SRF could be the new mantra nowadays. So we have a lot of sequels. I'm going to just skip this to the last point. I'm just running out of time, sorry for that. So I'll just go to this. When can you accept stopping treatment? That is, if you have a stable SRF, when the patient develops degenerative CME or ORT, when you have multi-layering, it's a sign where the treatment can be slightly slowed down. And if you have extensive RP damage and evolving geographic atrophy, again, you slow down treatment. So this is the algorithm for that. Persistent SRF ORT. And I just go to the last part, evaluating prognosis. Again, as I said, what evaluates a prognosis, whether your location is foveal, non-foveal, or foveal by extension. the nature of the disease, whether it's a typical AMD or a variant of the AMD with different modalities. If you see SHRM and it is vascularized, you can expect a poorer prognosis and the formation of more scarring. The presence of multi-layering is a good prognostic sign. The patients with multi-layering do not rip and do not bleed massively. The presence of a scar, you have to decide whether it is a scar with activity or a scar with just degenerative changes, and that can tell you whether to stop or continue treatment. And basically looking at the background changes and the choroidal features also. So the understanding is that now any treatment of AMD has only one reason, whether it is wet or dry, the prevention of atrophy. Dry AMD directly to atrophy, wet AMD, atrophy via scarring. So the whole concept is that the only thing that to treat is to prevent atrophy. Thank you so much.
Thank you, Uni, for the nice talk. Next, I call upon Dr. Parveen Sen. She will be talking to you on diagnosing and approaching the hereditary retinal dystrophies.
That's too long.
Everyone, and I thank Dr. Unikrishnan for giving me this opportunity to be here amongst you early in the morning. And after some very interesting talks, I will complete the algorithm for hereditary retinal disorders, what to do when you come across a case of IRD. So we know IRD are rare form of rare form of diseases, but they are, when collectively seen, they are not so rare. They almost form 20 to 25% of blindness, especially in the working age group, and which is most economically effective group. And the new standard of treatment, as has been recommended by the American Academy of Ophthalmology, includes early diagnosis, characterization of disease, genetic testing and counseling, and familiarity with the ongoing clinical trials for treatment of IRD. The early characterization includes both structural as well as functional assessment, and the functional assessment could be for the visual acuity, color vision, history of night blindness, nystagmus. But I think one of the most important things which you should not miss is refractive error. Almost 54% of the inherited retinal degenerations are associated with the refractive error, and myopia is the most common. Patients with ABCA4 gene defect, patients with congenital stationary night blindness are associated with high myopia. So whenever you see a patient of high myopia without a history of myopia in the family, one of the things you could consider is, and you should ask leading questions of any color vision defects or any night blindness which can be present, especially tilted disc, tessellated fundus, along with 6 to 7 diopter of myopia is actually pathognomic of CSNB and could have TRPM1 gene mutation. Perimetry is another form of functional assessment, and most importantly, of course, is electrophysiology. But couple of things you must keep in mind is the diagnosis of enhanced S-cone dystrophy. If you see an ERG like this, which has a similar waveform in photopic as well as scotopic readings, it is something which could be because of enhanced S-cone, and a single gene NR2E3 could be responsible for this type of phenotype. So without doing genetic testing, this is diagnostic of this type of ERG. Second, very diagnostic ERG is subnormal or non-recordable photopic responses with supernormal combined responses. So no photopic response, supernormal scotopic happens only in KCNB2. So these couple of things you must keep in mind. Second is fundus photography. Just to give you an example, on your left is the fundus photograph, a 90-degree image where you could label this patient to have cone dystrophy, but if you see carefully on a wide field photograph, this definitely is not cone dystrophy and is a widespread retinal degeneration, and the underlying pathology here was circle mutation causing retinitis pigmentosa. Not to miss is this fine RPE granularity in a child with an otherwise normal or without pigmentation fundus. Pigmentation takes a while to come, but if you see this kind of fine RPE granularity, I did ask for genetic testing, and this again was circle mutation, which seems to be the common form of mutation for retinitis pigmentosa. Macular colobomatosis kind of condition with RDH12, and of course fundus autofluorescence. When you see a patient of IRD, this is one indication where you must advise a fundus autofluorescence and never miss a typical pattern. A fundus autofluorescence which is abnormal with the peripapillary sparing could be due to underlying ABCA4. So if you do a careful clinical characterization, you already have some possible genes in your mind when you advise genetic testing. Autofluorescence can also tell you whether the disease is progressing. So this is what you call the Robson sign or the Robson ring. As you see it increasing in size, this is what is seen in patients with cone dystrophy, and you see it becoming smaller. You see this in cases of retinitis pigmentosa. Optical coherence tomography, these are some gross examples that the moment you see an OCT like this, you know it is adult onset vitelliform. OCT also shows you the area of ellipsoid zone which is presence, and so visual prognosis can be gauged from this. Some form of IRDs are associated with macular edema, and their presence needs OCT for treatment and follow-up. In fact, the EZ width of about 600 micron is necessary for any kind of gene therapy in future. This is one of the inclusion criteria. So OCT again is going to be vital. When you evaluate these patients with IRDs, you must do a fundus photograph, OCT, autofluorescence. Some of these OCTs can be pathognomic again and can show you progression of disease, and if you see this, the prognosis for visual outcome can be poor, and this can be explained. Autosomal dominant RP is associated with vitellomacular interface abnormalities, which could lead to CME and macular hole formation, and this should you think of the moment you see this kind of macular changes with RP, you should think of autosomal dominant RP. So when do you decide to have genetic testing? First and foremost, before you straight away go into blood sample collection for genetic testing, is you look for the family history and try to form a 3-generation pedigree for these patients. In spite of a good clinical study, you can still sometimes miss a lot of gene defects because more than almost 300 genes are known to cause IRD, and there is a significant overlap. So the American Academy Task Force has mentioned that for monogenic diseases like RP and Stargardt's, it is nothing wrong, it is nothing over the board if you advise genetic testing, and genetic testing should be considered. This is standard of care. So what kind of genetic testing? Would you do a whole genome, whole exome, a gene panel, or a single gene? Single gene sometimes can actually be more expensive because if you don't get this, you'll have to ask for another one. And gene panel, they are dedicated gene panels for RP, and then whole exome or whole genome, as the name suggests. We do a whole exome most commonly because almost 80% or 90% of the information and disease-causing variants are present in the exomes. So a whole exome is probably a good way to start with. If you do a whole genome, which is somewhere in most of the countries in UK do a whole genome for these patients, the number of uncertain mutations, you don't know whether they are really responsible for the gene or not, that can be increased, and the interpretation can become extremely difficult. Why do it at all? Why do genetic testing? You may argue that there is no treatment, so you don't need to do, but to accurately prognosticate the disease, to diagnose, to develop genotype-phenotype correlation, you must do, and in children, most importantly, I'll share some examples that it rules out syndromic disease. And this is how the interpretation is done. Usually this is done by a geneticist, so you need not worry too much about it, but some knowledge is important, and interpretation is important because clinical correlation is important. Here, you know, it's an example, typical case where USH2A gene has been seen. This too is typical, but imagine the genetic testing is normal, is not showing any variant. This does not mean that it is not RP, it's just that it may be a novel mutation which has not been seen till now. Another example, this was diagnosed as USH2A, but there's a rapid progression. We know USH2A RP does not cause rapid progression. Why was there decrease in vision? because there was an additional gene mutation in CRB1 gene as well, and that causes early maculopathy. So an understanding of this type of genotype, phenotype, and complex kind of inheritance can be understood as you do more and more of genotype in your cases. But there are problems, there are pitfalls. Single gene, we know best gene can cause multiple phenotypes, and that is because of variable penetrance. Same here. For Stargardt's disease, we know different gene mutations can cause Stargardt's type of phenotype. In children, most important, as I said, syndromic RP, especially senior loken. As an ophthalmologist, you may be the first one to diagnose that the patient has cone dystrophy. But if you advise a physical examination or if you do genetic testing, senior loken, these are the cases where the children will have acute renal failure and may need renal transplant at first decade of life. And this, again, it is a disease in progression in children, so you have to interpret it very carefully. Just sharing an example, this was an 11-year-old child who was first diagnosed to have achromatopsia, then cone dystrophy, then cone rod dystrophy because the disease was progressing. When I did ask the history, patient gave a history, already have undergone renal transplant at 11 years of age. So suspecting senior loken syndrome, I had advised genetic testing. Previous genetic testing was actually negative. When we redid it, because I had a strong clinical suspicion, we did find the CEP290 gene, and it is important because the parents were ready to take the child anywhere for gene therapy trials, and gene therapy trial for CEP290 is available. Unfortunately, it is only available for a specific variant. This variant was absent in the child. So actually, we saved at least the child a trip to US to check all these things. So gene testing can be very useful, and we are at a cusp where we can do these things. Another last example of Hermansky-Pudlov, we would have seen so many elmanotic patients, we send them back saying nothing can be done, but you are actually refusing them medical treatment, because if you do genetic testing and it is Hermansky-Pudlov syndrome, patient needs to be counseled for life-threatening conditions like bleeding diathesis, pulmonary fibrosis, which can be associated with albinism. So genetic testing comes with the high responsibility of genetic counseling. So this is my final algorithm, that history and clinical examination should be done. This should be followed by proper imaging techniques and functional assessment. Finally, genetic testing and counseling for these patients to look for eligibility for clinical trials, which may happen more and more in near future. So this is the importance of genotype-phenotype correlation cannot be overemphasized. Thank you.
Thank you, ma'am, for the wonderful talk. Next, I'll be calling Dr. Rajiv Raman, who will be speaking to you on diagnostic approach to how to approach a case of a diabetic retinopathy.
Thanks, Unni, for putting up this nice course. Next few minutes, I'll be sharing thoughts on algorithmic approach to manage diabetic retinopathy. There are certain guiding principles in treatment of retinopathy. You first classify it whether it is sight-threatening. Anything above severe NPDR, PDR, and DME becomes sight-threatening. You consider investigations based on the various stages and what is needed. Still, PRP is the mainstay of treatment in proliferative diabetic retinopathy. We classify diabetic macular edema as whether it is a center involving DME or a non-center involving DME. Definitely the glycemic control, the BP control, lipids, anemia, they are very crucial as far as management of diabetic retinopathy is concerned. And anti-VEGFs are still the first line of treatment in treating center involving DME. So you switch to in between anti-VEGF or switch to laser or steroids if it is a non-responder. OCT and vision are the key tests for determining the initial treatment choice and even on the follow-up. And in case of vitreomacular traction and in select cases of non-responding DME, vitrectomy has a role. Let's see how you manage DME. So we classify it whether it is non-center involving or center involving. If it's a treatment naive and it's good vision, you tend to observe. Vision is low, still the ETDRS guidelines play a role. You can do laser, do a monthly follow-up. Sometimes it may start with a center involving and on follow-up it becomes a non-center involving. These are the cases you can still, vision is good, you can observe, and if it is poor, you can go ahead with laser and monthly follow-ups. Then you repeat, if it's a center involving DME, if they have a good vision, definitely you don't want to treat them. That's what the DRCR net protocol VS taught us. And if it is a poor vision, you go ahead giving anti-VEGF injections. There's no magic number of 3 injections, but on each visit you tend to see the response, whether they are responding in terms of vision and OCT reduction. And if they are responding, you continue with anti-VEGF. If they are not responding or less responsive, still continue. But if it is a poor response, you can switch to another agent, or you can start using steroids. However, it's not one shoe for every thing. The size, one shoe size is not for all. The treatment algorithm is dependent on many other factors. There are certain patient-related factors. If the patient had a history of a cerebrovascular event 3 months, within last 3 months, you tend to avoid anti-VEGF. You can consider steroids. You can even consider laser. If it's a diabetic macular edema in a pregnant lady, if it is less, you can still watch. If it's in the early pregnancy and there is severe edema, you either do a laser or steroids can be given. However, it's in the last trimester, you can actually wait, because majority of them will have spontaneous recovery after delivery. If a patient is of a poor compliance, you consider intravitreal steroids. Even laser is not a bad option. Patients who have renal conditions, you start with anti-VEGF. However, on treatment, if the renal parameters are deteriorating, you tend to skip anti-VEGF or switch to steroids. There are certain eye-related factors. If it's a vitrectomized eye with a diabetic macular edema, we have shown as a multicentric study that early period you don't need to actually inject anything. However, if it's in the late period, you can go ahead with steroids. Even anti-VEGF works, but you require less number of injections for steroid. If it is diabetic macular edema is with PDR, anti-VEGF becomes the first choice. You can do definitely you need to do a pan-retinal photocoagulation, or you can defer it and do it a little later. If it's a pseudophakic eye with diabetic macular edema, you want to differentiate it, whether it is pseudophakic macular edema or a diabetic macular edema, and you can consider steroids in patients who have reached a plateau, or there is a persistent intraretinal fluid, or their vision is less. These cases you can consider steroids. There are certain disease-related factors. If it's a plaque of hard exudate in diabetic macular edema, you want to control dyslipidemia. Intravitreal steroids have a little edge, and you also can use adjuvant lipid-lowering agents. We also know that if it's a thicker retina, poorer vision, the newer agents like aflibercept or faricimab may be better. If there are vitreoretinal surface abnormalities, they do a little poor response, they need more injections. And if there is traction, vitreomacular traction, vitrectomy is something you can consider. So you start assessing the response, and if there is a poor systemic control, you do a appropriate referral. When they are poor responder, you also try to understand how many previous injections they have taken, the best response, which was it, and consider using the same drug when you are switching. If it's a chronic edema more than 6 months, you can consider steroids. And if on history you find some of the drugs which can cause macular edema, you better stop those drugs and just have a follow-up. Macular edema can go. So if a patient is on anti-VEGF pathway and you are reviewing it after some time, there is inadequate frequency of injections or visits, you get a suboptimal response, or even with that you may have an optimal response. If they have, you can encourage for a more frequent visits and injections. And if they cannot attend, if they are having frequent visit, you continue the same anti-VEGF and monitor. If they cannot have a better compliance, you can switch to steroid. And if they are having adequate injections and visits, or there is optimal response, you continue with the anti-VEGFs and monitor. If there is a suboptimal response, you can switch to steroid or switch to other anti-VEGFs. Let's now switch gear to proliferative diabetic retinopathy. PRP still is the mainstay as far as treatment is concerned. However, in patients who have a single NVE, patient is of good compliance, you can consider anti-VEGF monotherapy to start with. Poor compliance, definitely PRP is the solution. If there is PDR with no traction and the patient has of good compliance, you can still consider anti-VEGF as one of the options to start with. If there is a traction not involving the fovea, you do a PRP 2 disc diameters away from the TRDs. If there is a PDR with a center involving DME, you combine anti-VEGF with PRP. If it's an active PDR, even after completion of PRP, you can do a supplemental PRP. You can assess the presence of active new vessels. Sometimes you may have mature vessels which really don't need any treatment after that. If it is with NVI, you do aggressive PRP and anti-VEGFs, which are the mainstay. So the success of treatment of diabetic retinopathy is good control of systemic factors, a good compliance to follow up, and the good compliance to treatment. And most important, you must understand the patient journey. It is not a lone eye, it involves many other complications. Thank you very much. I would like to invite all of you for the APOTS Retina Meet and the Retina Summit in July 2025. Thank you.
Thank you, Dr. Rajiv. That's, as usual, that's a brilliant portrayal and the sequence of events in diabetes and diabetic macular edema. I'd like to invite Dr. Manoj, Senior Consultant in Vitreoretina Chaitanya Hospital, to give his talk about an approach to retinal venous occlusions.
Thank you. Thank you, Dr. Uni. I'll be talking to you on an algorithm-based approach to retinal vein occlusion. Now, we all know that it's an important disease too, along with diabetic retinopathy. It's a common retinal vascular pathology, and because of its implications, some of these cases, if left untreated, can lead to permanent visual loss or blindness. And more importantly, there is a strong systemic association with this disease. There's a higher incidence of cardiovascular events, including stroke, that is associated. So my algorithm is this: like whenever we see a patient retinal vein occlusion, first we would like to see if the patient, typically the vein occlusion is a disease of the older age group. But when you see a young patient, then these patients can be considered a distinct clinical entity because they have more favorable prognosis, the complications are less, and sometimes they have a self-resolving course. And we need to understand that nearly 1/4 of these eyes have an inflammatory basis. And the phenotype in these situations is usually a central retinal vein occlusion than a branch retinal vein occlusion. So, and then we would like to see if the occlusion is basically unilateral or bilateral. Predominantly, retinal venous occlusions are unilateral diseases, but when you see it bilateral at presentation, then this is seen in 4 to 7% of cases, and it means that you require some additional testing because the etiologies may be slightly different. You're looking at hypercoagulable states, hematological malignancies, or even inflammatory diseases. So these have to be considered. So even in unilateral cases, one needs to first rule out if there is an inflammatory sign that is associated. Look for inflammatory signs. Like for example, if you have a BRVO and if it does not respect the typical AV crossing change, then you're thinking of an inflammatory vein occlusion. But we know the commonest cause is thrombotic, and where we would like to classify vein occlusions into central retinal vein occlusion and the branch retinal vein occlusion. HCRVO, hemicentral retinal vein occlusion, is considered part of CRVO because they share the same pathogenesis and in terms of prognosis and treatment. And overall they are classified into non-ischemic and ischemic. And we also know how to differentiate them. Ischemic CRVOs typically have RAPD. If you take an FA in these patients, they have extensive CNP areas, and even on the ERG, there is a reduced B wave amplitude. All this can help us to differentiate between an ischemic and a non-ischemic CRVO. BRVOs, on the other hand, we would like to see if the BRVO suggests a macular BRVO, whether it's a major sectoral branch vein occlusion, or is it a hemispheric vein occlusion, where one half of the retina, which is supplied by an abnormal vein, the AV crossing change is affected, and therefore now you have a picture which looks like hemi-CRVO. So this needs to be differentiated because the prognosis is slightly different between these two entities. So, and we also know that if you perform an FA and then if the CNP areas are more than 5 disk areas, you would like to call it an ischemic BRVO. So investigations, in a typical case, these are the common investigations that you would do. But when you have patients under 50 years, or when you have a bilateral presentation, then you need to look for antiphospholipid antibodies, antithrombin 3 levels, activated protein C resistance, factor 12, and even look at some inflammatory markers, treponemal, non-treponemal tests, and even quantiferon gold. So in terms of prognosis, the first thing that I would look at is the baseline visual acuity, because we know from the CRVO study and from the BRVO study that baseline visual acuity is very important. If you have a good visual acuity at baseline, then these patients tend to do well with or without treatment. With poor visual acuities at baseline, like worse than 660, these patients, in spite of good treatment, they would still, many of them may end up with poor visual outcomes. Now, this is the same thing with BRV also. Most of the studies have shown that the final visual acuity is strongly dependent on the initial visual acuity. The next thing we would look at is we would normally perform an OCT in these patients to look for macular edema. Subtle macular edemas may be missed, so therefore it's important to perform an OCT in all these patients. And we look at the CFT. The CFT is again the next important prognostic marker. When the baseline CFT is higher, then it is a poor prognostic marker. It is a predictive factor for final visual acuity after anti-VEGF therapy. Like there are studies which have shown that if the CFT is more than 500 microns, so these patients may tend to do better with steroids than anti-VEGF agents. And we also look at other biomarkers. We look at the presence of intraretinal fluid, the subretinal fluid, hyperreflective foci, and other OCT biomarkers. SMT is generally considered a good biomarker, and people believe that it may respond better to steroids as against intraretinal fluid. Intraretinal fluid, especially in the ganglion cell layer, is believed to be very detrimental and causes very poor visual outcomes. We also look at these biomarkers where the disorganization of the inner layers, called the drill, or even the disorganization of the outer layers, which is now called as a drawl, where there is an ellipsoid zone loss. So these are bad prognostic markers. It means that there is it is a strong association with macular ischemia and poor outcomes with whatever treatment that you give. Also, you look at the red arrow shows the prominent middle layer membrane, and the yellow arrow shows the PAM-like lesions, middle layer maculopathies. So these are lesions which tell you that that the severity of ischemia is more, or there is an arterial component to that, and the prognosis again poor in these patients. Like this patient that we saw here, this patient had macular edema with macular ischemia, and in spite of anti-VEGF therapy, this patient is not doing well. And then we realized that there is a small dilated arteriole sitting there, which is like more than 200 microns. So this is a retinal capillary macroaneurysm. So this has been reported in both diabetic macular edema as well as in vein occlusion. These patients are resistant to anti-VEGF therapy. So doing a laser to this lesion and with the orthodex, you see a good anatomical response in this patient. We also have understood that ultra-wide field imaging is very useful in these patients because there is a lot more ischemia that we pick up on these imaging system. There is an ischemic index, which if it is between 35 to 45%, it's strongly suggestive of ischemic vein occlusion and poor prognosis. And these large CNP areas are associated with recalcitrant macular edema and higher anti-VEGF burden. And now with the advent of OCTA, this is the intralight system that we use now, which gives us wide-angled OCT images, like 29 into 24 images. You can pick up all the perfusion gaps, you can pick up these abnormal vessels, and you can also this is a patient where you see a lot of collaterals that you see in the sectoral region of the branch vein occlusion. And identifying collaterals is important because now OCTA-based studies have shown that collaterals are picked up much earlier, not at the 3 to 6 months of the disease. It's seen in almost 82% of cases, even at baseline. And if you have a collateral, it's a good prognostic sign. Earlier the collateral develops, there's a chance that your macular edema is going to get better, and the resolution and the final visual acuities are going to be better. Also now with the Octa, we can now look at the deep capillary plexus as against the superficial capillary plexus. Being a venous disorder, you would see more changes in the deep capillary plexus. And there are a lot of poor prognostic markers that have been described. The ratio between the deep and the superficial plexus. And all these variables have shown us that if there is a deep capillary plexus which is severely involved, then these patients have a poor visual outcome. They have persistent macular edemas, and there is an increased anti-VEGF burden. Like in this patient here, this patient was treated and had a good anatomical response, but if you look at the superficial capillary plexus that is shown there, it looks nearly normal with the collateral, but the visual acuity is poor. But if you look at the deep capillary plexus, you can see there is an enlarged FAZ, and it is this deep capillary plexus ischemia, selective ischemia, that could explain the visual loss in these patients. We know that anti-VEGF therapy is a mainstay of treatment in these patients, and we have understood from the trials that you need to be intensive in the first 6 months of therapy to attain meaningful vision gains. So we also now understand how to define a poor responder. A 3-month guide is a good one. Like if you have at 3 months you do an OCT assessment, if there's a good response, good complete resolution of fluid, is a good responder. But if you have less than 10% of decrease, then it is a poor responder, and if you have around 10% or more, then it is a partial responder. So now this difference can be made out at 3 months, and you could use this as a guide to continue with your therapy. Also know there are guides which biomarker indicators which tell us that some of these may respond better to steroids, like presence of a thicker CFT at baseline, or like presence of hyperreflective foci or persistent subretinal fluid. All these are prognostic markers which tell us that steroids may be better than anti-VEGF. So that they will tell you when to switch to steroids. So this is my algorithm. In a non-ischemic CRVO, when you have macular edema, we start off with anti-VEGF and look at the 3 months trend. If it is a good responder, continue, and it's a good prognosis. But if it is an inadequate response, you look at the OCT biomarkers at that point of time, look at poor prognostic markers, and you could persist for another 3 months, because the trial says that some people may respond a little later. And at 6 months, if they don't, you need to switch. Or you could even switch at 3 months to a different agent. And I think the time's up. Sorry, I'll just take 2 minutes. So in an ischemic CRVO, obviously you would also add laser photocoagulation along with this, and the protocol essentially, the OCT guidelines are essentially the same. Look at the good responders and the inadequate responders and go ahead. And BRVO also, so there's not major difference in treating macular edema between the two entities. Looking at OCT guides, you can decide whether or not you need to switch or continue with the anti-VEGF therapy, but you need to monitor for macular edema, macular ischemia, which are poor prognostic factors, and also treat whenever there is a new vascularization or its complications. So this is my final take on unfavorable outcomes. You need to pause at 3 months and 6 months and reinvestigate. Look for unfavorable outcomes on the OCT. Look at ultra-wide field imaging or OCT clues, and then reinvestigate systemically at that point. Look at other comorbidities, and then have a low threshold for modifying the protocol or agent or adopting other treatments. And targeted PRP, though not proven to be consistent, I feel, it may not be detrimental in these patients and should be adopted. Thank you.
Thank you, Manoj. We're moving on to the last talk of the session, which will be by Colonel Pradeep Kumar. He's a professor of ophthalmology from the Army Hospital, New Delhi. So he'll be talking to us on brolucizumab in pachychoroid spectrum. Over to you, Pradeep.
Thank you so much for the opportunity to present. Firstly, my job has been made very simple by Dr. George. So he has told us all about identification and how to go about treating the pachychoroid spectrum. I will begin with why we are talking about brolucizumab today. We all believe that it is the most efficacious anti-VEGF we have today, but yes, there are safety concerns. And while the Western world has adopted faricimab, we are yet to see the durability set in the first or second injection. It takes time for the durability to set in, and the peak efficacy as per us has been lower. Now, how to prove this point? So what has changed in our practice in past couple of years is that we have moved to biosimilars compared to innovator in terms of ranibizumab usage, and post-COVID, all of us have learned the importance of longer inter-injection intervals, and this is how our practice change at Army Hospital R&D. From giving close to about 3,500 injections in 2021, our total number of injections are gradually reducing. And it is not so that our number of patients are reducing, our number of patients are actually increasing. But this has happened because, one, the ranibizumab part has been taken over by the biosimilar, and two, there has been an influx of aflibercept, brolucimab, as well as faricimab, which are effectively reducing our total injection load. As you can see, we started using brolucimab way early in 2021 due to our 2 RCTs which were going on, and they have continued to find a place in our clinics despite the safety concerns. The faricimab usage started last year and is gradually picking up, and it has actually helped us in reducing the total number of injections by close to about 3/4 of what we were injecting initially. So these are initial take-home messages from these slides, that as ranibizumab has seen its way out of our clinics, in couple of years we might see a similar trend with aflibercept, though aflibercept HD will pave a new way forward, and the perceived severe adverse drug reactions of brolucimab in our hands have been 6 in 2,876 cases, and we can say that none of our patients have gone to poorer visual acuity from where they initially started in any of these 6 cases. So our initial work with brolucimab got published in 2022, where we spoke about neovascular AMD. In this case, we had taken treatment-naive neovascular AMD cases, and the best corrected visual acuity at the end of 52 weeks was a shade better than aflibercept, but it was not statistically significant. What was statistically significant was a reduction in central macular thickness. The molecule brolucimab had a much greater drying effect, and this drying effect was specifically seen in the subretinal fluid compartment. I'll give you one example of a peaky choroid spectrum disease in this gamut of neovascular AMD diseases, where right after one injection, 18 May 2023, this patient has been on continuous follow-up, continues to maintain 6/9 vision with a little bit of metamorphopsia, and has not required a second injection. So this molecule is pretty strong. Now, after 104 week compiling 2-year data, we have shown that the inter-injection durability is 12.7 weeks with this particular molecule. Though we are continuing with our faricimab study, we have not been able to achieve this figure yet with faricimab. There were just 3 adverse drug reactions in our neovascular AMD subset. So the question which was frequently asked, why we did not do a subset analysis of PCV cases. So we sat down on it and started looking at the literature, which told us that though the visual improvements with aflibercept and brolucimab are similar in PCV cases, the regression of polyps is greater, and more evidence suggests that with aflibercept, just half of the patients achieve this regression, while it is close to about 3/4 with brolucimab. So the superior anatomical outcomes were established in other studies also. In our subgroup, we could identify 19 ICGA proven PCV cases in brolucimab subset and 17 in aflibercept subset, which were about a decade younger than rest of the population in our study. And this was our methodology that we followed, and the best corrected visual acuity changes show that there is an early achievement of better visual acuity with brolucimab, though both the molecules try to become similar by about 52 weeks. Until about 104 weeks, the effects remain. From 52 to 104 weeks, these patients were kept on PRN regime rather than a strict 4-weekly mandatory follow-up. In the central macular thickness group also, we realized that in first 12 weeks, the drying effect is much higher with brolucimab, which is retained till 104 weeks. Now the key issue is how many number of injections are given. We realized that with aflibercept, the number of injections which are given remain much higher till about 104 weeks. So our inter-injection durability in PCV subgroup has been a little lower than the classical neovascular AMD subgroup at about 9.9 weeks, say about 10-week interval. Now we also started thinking that what about the rest of the peaky choroid spectrum? Why we have not investigated this molecule in CSCR? So we looked at the evidence, and people were already talking about an impact of brolucimab in non-calcitrant CSCR cases. The largest study came from China, where they had 3 arms comparing PDT versus brolucimab versus aflibercept, and they also showed that with brolucimab they were the faster drying. So this we like to show our series of CSCR cases which were chronic, had a central leak within 1000 microns of fovea, and there was no CNV on either ICGA or Octa. In our first case, we achieved a partial response with a small drying effect. But in our second case, this was the cockpit crew wanted to go back to duty faster. These are various segments of the same macula. The macula became completely dry at 14 day and has remained so since then. So we have had 9 such inclusions in our series, out of which 7 have shown drying effect, 5 with complete drying, 2 with partial drying, 2 patients did not respond, and a single dose of brolucimab was sufficient to cause the drying, and we have not had to inject a second dose in any of these patients. Lastly, we also wanted to understand that what is this molecule causing in cases of picky choroid neovasculopathy. So the evidence shows that when PNV cases are treated, almost 64.7% showed complete resorption of both IRF and SRF, while about 1/4 cases did not respond completely. So we tried to look at isolated PNV cases which were being treated only on the indication of metamorphopsia and diminution of vision, and on ICGA we have not seen polyps in these cases, and on OCT there were no sharp or thumb-like PETs. 13 such cases could be identified in our case series. This is a retrospective data. We have identified an inter-injection interval of about 17.6 weeks. So once you treat PNV cases with brolucimab, you find an even larger inter-injection interval compared to neovascular AMD and PCV cases. So to conclude, I like to say that brolucimab is efficacious in picky choroid spectrum. The higher inter-injection interval in PCV, the confidence comes from our RCT data. It tells us that it is close to about 10 weeks inter-injection interval. We are not talking here about the increased best corrected visual acuity gains because they were not statistically significant, though I'll say they were about 0.3 logmar higher. And there is a higher inter-injection interval in PNV based on our retrospective data. And for CSCR, though we have a very limited data set today, but when a patient, you have a central leak and micropulse laser is not working in these cases, this is one molecule you can give a try. Thank you.
Thank you, Dr. Pradeep, so for those insights about Broluci, and for all of us, it's kind of like a rescue drug for some most cases that we use it as a rescue therapy, and it's quite efficacious. Thank you so much. Do we have any questions regarding any of the talks previously, any of the topics, the pachychoroid, dry AMD, wet AMD?
What is the panel's lookout for central leak in CSR where nowadays PDT is not available, and do we recommend anti-VEGF as a try for CSR?
I'll just divert that to Dr. George, who has access to PDT, the only person in India probably, but he can take that.
Yeah, no, ideal treatment is PDT. We are doing, but limited availability. That's the best option that you can safely do. You're not treating the retina, you're treating the choroid only. But then in the absence of that, the next best option is doing micropulse laser. That is so at least if you're talking about a chronic case, with all chronicity changes that we discussed then it might be, if it's an acute or recurrences, it works well. Only thing is your parameters should be correct. Like we do something called sequential micropulse, wherein find out an extra macular threshold and then go up sequentially. So that's a least traumatic way of doing a subfoveal treatment. So micropulse is the next best option, but then we found in the study that 30% of them recur by 6 months. So you are not altering the disease or modifying the disease. The only way of modifying the disease is with PDT, where you reduce the choroidal vascular hyperpermeability by targeting the abnormal choroidal vessels.
I'd like to add a point to that, being that when you say anti-VEGF for CSR and you see some patients work, there is one subset that we have to be very careful. That is a PNV subset. So when you diagnose CSR, you have to make sure that you're not dealing with a PNV. And if it's a PNV, those patients do respond to anti-VEGF. But often, a very casual look at it and you think it is CSR. And when giving anti-VEGF in those patients, a typical CSR patient, the mechanisms are not fully understood. A possible mechanism is a generalized reduction of the choroidal hyperpermeability, but that is not a focused treatment. And there is no consistent proof saying that anti-VEGF is going to work in CSR, or even worse, chronic CSR, when the RP changes happen, and that also contributes to the exudative phenomena.
So these, even with brolucizumab, as he has mentioned, PCV, it works very well. But then even if you're trying in a chronic CSC, as Dr. Unni mentioned, you're targeting that with more potent agent and more choroidal penetration, RP penetration, you're looking at transiently reducing the choroidal vascular hyperpermeability. But then you need to weigh the risks and benefits of repeating these injections. It's not like a one injection and cure of it. You need to keep injecting even agents like brolucizumab.
Hi, good morning. Dr. Unikrishnan and team, lovely course. I have 3 questions, and all 3 my questions are for Dr. Unikrishnan. In your talk, you mentioned briefly about the multi-layer PEDs and having a little better prognosis in terms of progression. My question to you is, did you look at these PEDs? Were they de novo PEDs or were they secondary multi-layer PEDs? Second thing is, did you do did you do sub-analysis as to how many of these were actually PCV related and how many of these were occult? And my last question on this is, did you look at the choroidal clefting as well in your algorithm for prognosis?
Okay, so basically in the algorithm we just skipped over this, as why we say multi-layered PEDs have a better prognosis is that multi-layer PED shows a type of chronicity in which the fibrosing element prevents a rip, which is a catastrophic event. It also is associated with, let's say, a suboptimal anti-VEGF response. Both of them are correlated. The whole fibrosis or layering happens because the disease is smoldering. And the thought process is that the layers are a form of sealing off of the activity at different layers. That is the first point. Now, regarding the de novo and the secondary formation, we have brought out a paper about de novo formation, that is on the first instance, but till now multi-layered PDs were only thought to be secondary to anti-VEGF therapy, chronic anti-VEGF. So in our paper we have mentioned about treatment naive people who are presented with multi-layered PED. So in that subset we have found that again we've looked at the choroidal clefts, the presence of an early choroidal cleft and the response to anti-VEGF, and it is there is a difference between the response in an early and a late choroidal cleft till now. But I'd like to say that again we have a new paper about the use of brolucizumab, which we have, I think it's up for submission. There is the ability to collapse a multi-layered PD with brolucizumab now. That is, a layering collapses, it becomes a scar. It is not permanent again, but the first, one of the first papers in first appearances about the ability to collapse a multi-layered PED, and that has happened with brolucizumab. So prognostically, the presence of a cleft shows increased hydrostatic pressure beneath the PED, more exudative phenomena, more resistance to anti-VEGF. The presence of multi-layering shows a resistance to anti-VEGF. Those are the bad parts of it, but the worst part of it is the possibility of maintenance of visual acuity for a longer time, the less chance of a rip and a massive hemorrhage, the less chance of a scarring other than what is happening underneath the RP.
Yeah, thank you so much.
Thank you.
Actually asked for that reason because in real life we don't necessarily see it being associated with good visual prognosis, but yes, I mean chances of it ripping or causing a catastrophic event is very zilch. Thank you.
Thank you.
The opinion of the House about in pachychoroid CSA, what is the role of brolucizumab and your experiences with that?
We have very limited experience in that because that's like there are few people trying that, but then as I mentioned, it's not driven it's not a VEGF driven disease. Firstly, if you're trying to target the treatment, you're trying to use an anti-VEGF which is very highly potent and better penetration to the choroid and trying to reduce the choroidal vascular hyperpermeability. So we are not, it should be the last option where you have not as a first line therapy, last option where you're left with nothing, and then you should be present when benefits are clearly explained to the patient, and if he is willing, then do that, but then be, some reports have shown reduction of fluid, the cystoid and the subretinal fluid. So I am aware of that, but then it should be used as a last option.
It's basically a spectrum. So I have patients which were chronic CSR has converted into PCV after 5 to 6 years. So now we know that PCV patients respond best to brolucizumab and aflibercept. So if we can target these patients early, then we can get some kind of resolution, specifically in pachychoroid diseases.
I think there's a small point over there. It is the deviation in the pachychoroid spectrum is not necessarily CSR to PCV. It is one step ahead of that. It is your pigment epitheliopathy can convert to PNV, and PNVs can convert into type 2 PCVs, that is polypoidal CNVMs. So at any point of this disease, if we do not look at the OCT imaging findings carefully, we can misinterpret a PP as an old CSR, a PNV as a current CSR, and as it goes to the polypoidal stages of the disease, we may think that we're dealing with an exudative CSR rather than a neovascular component. There are studies that talk about CSR getting converted to PCV, but in this era where we know more about the background of the disease, we're probably dealing with a neovascular component in the disease slightly earlier in the course of in the continuum. It's a continuum rather.
So you're talking about one sequelae of chronic CSC developing later on, but that doesn't happen in all patients. The other sequelae is something called cystoid macular degeneration. The other sequelae is patient developing macular atrophy. There are only a small subset which proceeds from CSC to, so it is not like you're preventing PCV, but then there are other sequelae, just foveal thinning, cystoid macular so CNV is one sequelae where it responds to anti-VEGF therapy, no, but then it's an overkill if you are trying to prevent a PCV is what I believe.
If nothing works and we don't have PDT, like this patient what I'm talking, I did an PDT for this patient, and this patient converted to PCV after 6 to 7 years.
Okay, thank you so much. I think thank you all for the interaction at the end and the attending our course. It's a pleasure to present before you. Thank you.